This has fostered strong strategic partnership among family planning stakeholders in Nigeria through joint monitoring and reporting on key thematic activities of the family planning CIP, as well as providing opportunities for better coordination, mutual accountability, and alignment towards achieving the goal of a CIP of 36% by 2018. Thank you very much.
Thank you, Professor Okpara. We'll give you extra time. But please, I would like other presenters to try and keep to time. We will give you a brief summary of Professor Okpara's presentation just before we start asking questions. So the next presenter is Abdullahi K.M. And he's presenting on behalf of Odeku M, Ululano O.O, Akiode A.A, and Ibiawuchi C. I think this is a Nuri group.
Thank you very much. Just to give you background to the presentation, this presentation is KISS, and the presentation just made on CIP Cluster Implementation Plan actually sets the tone for this implementation. Because what we're used to is single interventions on advocacy, on service delivery, and demand generation. But what this intervention three-pronged approaches of advocacy, demand generation, and service delivery. If you do a single intervention, you won't have the same yield as you have when you do these three-pronged approaches. So, by way of definition, scaling up as a concept is basically an embedded project, concept within program interventions. And it looks at intensification of interventions. And what is critical about it is the fact that it has to be intentional from start, both in Nigeria and also in southern Nigeria. And underlying that intervention basically and ensuring that the critical stakeholders are carried along from start. And basically what we're scaling up. And again, to say that scaling up actually indicates a haste and urgency, particularly to achieve the given goals of the CIP, the blueprint, that 6% for Nigeria, and also the individual state level intervention. To carry out this intervention is basically looking at a stepwise process of embedding an intentional process of scaling up into the intervention right from start, to ensure that we are planning to scale up and then looking for those results. This is the proof of concept that the project doing integration. That means using existing services. Integrating this into existing services in facilities. So we're not creating anything parallel, nothing is new, but we are continuously interrogating our intervention and also continuously gathering the evidence for scale up. And we also use this model, which is the additional model. It's a predictor of utilization of services. Now the additional model, which is a 10-point factor, indicates that the more factor that an individual scores, the higher the potential of utilization of the services. And this is the three-reinforcing process of advocacy, demand generation. This is the three-pronged approach. So, institutionalizing stakeholder engagement from community to continue to provide pressure, to ensure that those services are available, that the resources required to expand the services are available. And this is because of the cultural and social norms and perception of people. And then we are also continuously engaging the media to ensure that people are aware of what the services are and also what they need to understand. And of course, the demand generation component basically is a communication campaign combined with social mobilization campaign in communities, which drives demand into the facilities. And these are some of the activities, the services that are rendered under the service delivery, we have capacity building, we have integrated supported supervision, whole site orientation, and then we'll have the IDEA program, which is basically an integrated distance learning program which supports the training and also the OJTs. And then, of course, we reposition. Often what you see in facilities is the fact that the family planning unit is the last to be allocated, and it has the lowest room, and the services do not have equipment, and they are not, the units are not friendly. So we renovate those facilities within 72 hours. That at close of 72-hour concept is actually a non-disruptive concept of service delivery to ensure that at close of work on Friday, we start the renovation, and by Monday morning, the services are available to the people without dispute. One, midland into the delivery of the services in the sites where we operated, we saw a huge boost in terms of uptake of services. Over 300,000 women took services basically on outreach alone. And activities, there was a significant understanding of the issues and also the activities that were provided in the services that are demand generated, but insignificant in terms of the logo of the project. Here, even though this is distorted, basically what this is showing is the fact that now for married women, there was a significant site. The next one actually shows the lowest quintile. If you want equity, you have to target the very poor, because those are the ones that cannot access the services of. So basically, in terms of scaling up for advocacy, you need to continuously involve the stakeholders. Ministry of Health has to be carried along and ensure that the resources are allocated. And you need to engage decision makers both at community, structural level, ensure that civil society's capacity to challenge the system is built. For services, we must continuously interrogate what services we are providing, the quality of services, and also the intervention, the scope and the spread of the intervention, to ensure that we are reaching the very vulnerable, and also address all weaknesses that exist using quality improvement teams within facilities. Now, for demand generation, community must continuously be educated of myths and misconceptions. And we must continuously interrogate intervention. Now, in conclusion, they need to deal with all issues around resources, and also you have demand generation driven into facilities. You see a remarkable increase in contraceptive prevalence rate, and we've seen those remarkable increase. Same data, and the difference now that we're seeing in terms of gap between the content and context, in which case the three-pronged approaches, of course, we need continuously nurture champions with. In terms of the Ministry of Health, it's very expensive because you have attrition at that level. And then demand generation is also a continuous process that you need to within the community. So these are the references, and if there are
Victor, stocking patterns and the pricing of family planning commodities in patent medicine.
Good day, members of the panel. On stocking pattern and pricing of family planning commodities. Thank you. I'm actually making this presentation on behalf of the authors, guide us through my presentation with this outline. The background, patent medicine stores would realize that they comprise a sizable chunk of the private sector, that's the private sector, and they also contribute substantial proportion of healthcare in developing countries. Like the ACT Watch in 2014 discovered that there are over 43,000 operators. There are over 43,000 patent medicine store operators in Nigeria. And in Lagos State, there are about 424 pharmacists. In 2015, The Lagos Family Planning Landscape Analysis that was put together by the trio of CCP, DKT, and Mary Stopes revealed that about 92% of retail from these two categories of providers, informal providers, as the PMS and the pharmacy shops. And we know that availability and costs are key supply side factors in family planning programming. So therefore, examining stocking pattern and pricing of family planning commodities at these retail outlets will help programmers ensure increased access to family planning services for men and women. The objective of the study was to examine the stocking pattern and the pricing of FP commodities in patent medicine store and pharmacies in 6 cities in Nigeria. And what we did was that we looked at the longitudinal MLE NORI 2014 pharmacy and PMS surveys that was conducted among 433 pharmacies and 540 PMSs across 6 cities of Abuja, Benin, Ibadan, Ilorin, Kaduna, and Zaria, and we used descriptive statistics to examine and understand the pricing and stock pattern in these 6 cities. So our results for the pharmacy, we discovered that the mean age of the respondents was 35. The range was actually between 21 and 49, but the mean age, the average age was 35. Interestingly too, for the patent medicine store operators, the mean age was also 35, but then it was the range, it was plus or minus 12. And we realized that 78% of the pharmacy operators, they had a tertiary education, while those of the PMS, just about 52 had a tertiary education, and about 1/3 of the PMS operators had professional medical education. Looking at the sum of 4 methods, and male condom was the predominant method that was stocked by at least 90% of the shops in all cities. Then also, at least 80% of the shops in all cities, they stocked EC and COP, emergency contraceptive, and combined oral pills, while only 17% stocked POP. So it means in all pills, they stocked pills, but POP, that progestin-only pills, was the least stocked in these stores. Now, beyond contraceptives, we also looked at injectables and implants, and these slides just show us that, yes, the stock implants, we can see that for Kaduna, it is we can see it as high as 95 points. It is high as 85.2. Not seeing my figure well. It is high for Kaduna there. Yes, the stock injectables, but then implants, there is a long-acting, the patent medicine store. Apart from Kaduna, where about 59% stocked a minimum of 4 methods. In other cities, less than 42 stocked up to 4 methods. And patent medicine stores, with at least 81% of these stores in all cities stocking male condoms, while 50% in all cities stocked emergency contraceptives and combined oral pills, with only 18% stocking progestin-only pills. We also looked at injectables too, and implants in this category of providers. And we can see that for injectables, it's interesting to know that they are not licensed. This category of providers, as the patent medicine vendors, the shops, they are not licensed to provide injectables, but we can see that a very high proportion, especially in Kaduna, actually provide this method of contraceptive. And for implants, even though it's just Ibadan and Ilorin that are providing these methods, but it's something worth looking at. For the cost now for pharmacists, the cost of contraceptive methods, it's actually varied across methods in all 6 cities. And well, the average cost, like for instance, for COP, that's a combined oral pill, for example, you can see that it went for 69 naira averagely. Then for the PMS also, we noticed the same pattern, that the cost also varied. And looking at COP2, the average cost for Abuja was high at 232 naira and about 63 naira in Ibadan. So in conclusion, stocking of family planning methods, it's high in both pharmacies and patent medicine store across 30 cities. although PMSs can only resupply pills. For that of PMSs, it's quite interesting if we can recollect the slide we saw, the chart showing the injectables that they are not licensed to supply. They are only licensed to actually resupply pills. They are not allowed to initiate treatment of pills. So of course this study has revealed that yes, they provide this method, and then the cost of contraceptive methods varies widely across cities for various methods. So what's the implication for programs? To assess their dispensing practice in order to know how best they could further be engaged. In addition, about 1/3 of patent medicine store operators, they have clinical backgrounds. From what we saw, 1/3 of them have clinical backgrounds. Over 20% of them are nurses, and some others are engaging them in order to ensure increased access to family planning. Thank you.
So just to summarize all three presentations, we had the first presentation by Professor Akpala, and it was mostly about the costed implementation plan that the technical support unit of the Federal Ministry of Health has worked on, and he described the process, the stakeholder engagement, and what is a more harmonized process for how we create our family planning work plan. And one of the key outputs of this work is the fact that there's a harmonized 2016-2017 work plan that has been developed for family planning. Overall, the conclusion from that is that having a costed implementation plan, which I'm sure everybody will agree with, will help foster stronger partnerships, improve coordination and mutual accountability amongst all key stakeholders in the family planning space. And I'm also aware that this process has now been taken to the sub-national levels, and multiple states across the country are in the process. Talked about the experience of the projects with scaling up family planning approaches. And I think some of the key takeaways from that is the fact that they used the ExpandNet framework, which ensures effective scale-up, and they adopted the horizontal scale-up approach. He also talked about the fact that it was and at this where they worked in. So they worked in 6 cities. They did not create any parallel systems, but they worked closely with the Federal Ministry of Health and other partners on the ground and ensured that it was a process that looked into supply, demand, and advocacy, where advocacy focused on budgets and policy, strengthening policy for family planning. I think it's key to note that this is where they worked. We saw that in Zaria, they had the highest increase there with about 15.7, almost 16 percentage point increase in CPR, which is phenomenal, and an average of 11.5% across Abuja, Ibadan, Ilorin, and Kaduna. So I think coming out of the second presenter's presentation is that for us to really take projects to scale, we have to recognize that it will occur in a complex and adaptive mindset of taking them to scale, which I know that in the public health space is one of the biggest challenges we face. We always have pilots, and then by the time we need to scale them up, because of the way we had designed it from scratch, then we find out that it starts to fail at that stage. Our third presentation, also from NURI, was about the assessment that was conducted from 2014 across patent medicine stores. I found this to be particularly interesting because not only does it confirm what we've been getting out of the demographic household surveys that we've had over the past couple of years, that majority of Nigerians seek healthcare in the private sector, but it also shows even how much more they seek this healthcare for family planning specifically in the informal sector. It also shows, I was particularly struck by the information that some of the presentation, but it would be interesting to know what the breakdown of the cadre of some of the PMVs was. So were majority of them choose, were they nurses, retired nurses, or how do they provide these injectables to the clients when they come? But I think overall, it confirms the fact that a lot of our private sector carry these commodities, and there's a need for us as policymakers to start to explore the opportunities that exist through the private sector as we think about scaling up approaches for family planning. So that's a summary of the 3 presentations, and we'll now open the floor for questions and comments. Thank you.
Thank you. Thank you, Dr. Fashaw. Please, when you're making comments or asking questions, please start by telling us your name and ask questions or make comments. Thank you very much. Yes. Okay.
Dr. Kichukwu Emmanuel, my question is to you. I was excited when the topics about use for determining who is a strategic partner. I work for on the health system where I was mandated to go and seek out the 2015 December, we incorporated missions. In moving forward with the CIP, and you said there are 6 and you're talking about strategic partnership to scale up. I think this is time to ventilate this landscape so that everyone can be met at where they are, so that we can really scale up the CPL. Thank you very much.
Thank you, Mr. Chairman. The name is Sheikh Salahuddin Busairi from Advocacy Network of Nigeria. First and foremost, on behalf of my constituency, we want to express our appreciation of what we've been experiencing as far as this campaign for the promotion of family planning to be part and parcel of our system in Nigeria. Particularly, we appreciate what we've been able to realize through the interventions carrying on by NORI from within our community. And that is one thing that we are concerned that being utilized by NORI in Nigeria. And we wish that the Nigerian public will always imbibe that. It's an issue that can always help us through if proper attention is paid to. Our concern is to make family planning becoming norm. Another issue is this issue of CIP, Costed Implementation Plan. To mention how this could, we believe that this conference could always address it, so that representatives from AAFP and see that that CIP is relating to family planning, and if such has been programmed, do we have effective implementation of it? And I want clarification on the issue of blueprint, just to get ourselves away from being confused that whether blueprint is available or CIP is a replacement of blueprint. Thank you very much.
Thank you, and I want to appreciate the wonderful panelists for a very interesting and insightful presentation. My question and also a comment goes to Professor Akpala still. And my name is Margaret Bolaji from Population and Reproductive Health Initiative, and also the youth representative on FP to young people and adolescents are about to enter their reproductive years. So usually when we talk about strategic partnership, even in the costed implementation plan, my question is, were young people and adults in the program? I'm talking about if they were even represented while the planning and the design of this was done. So as a young person, and we know that it is important that we talk about family planning too in relation to young people. So we're in preparing the costed implementation plan. Thank you.
to the second person who spoke. The CIP is a wonderful document, but going forward, what's the steps for implementation? We know some states have gone ahead to develop their own CIP, a document on the shelf that starts to gather dust. What steps have they made to, in the CIP that budgets, we can now have budget lines for family planning at the state level and at the local government level? We know how difficult it is to come out with the budget code. Has this process been simplified so that implementation no longer becomes a problem? And I think we need to move from the narrative where we're always speaking about policymakers. We need to start talking about policy implementers. We have all the wonderful policies, but how do we implement this going forward? Thank you.
Good day, the panel of beautiful and handsome presenters. I am Mrs. Victoria Oluwafemi Agboro. I represent Pastoral Hospital. Patrick is my husband's name and I'm Victoria. So, from Lagos. I represent, I came with the crew from Lagos State. I am personally concerned about high sense of ignorance and false perception. As a clinician sonographer, I am from the riverine parts of the country. I have been able to reach out effectively with good rapport and educate them positively with good response from the clients. But I continue to wonder because I go to the riverine area. For instance, from Apapa Wharf to Bariga Wharf, we have more than 82 quack hospitals, clinics I mean. So, and I always see myself alone going to meet them because I am from the riverine area, I'm a manager. So, I want to know, is there anything put in place to assist all those ones in the riverine area, not only in Lagos State? Because most of them, when I interviewed them, they said, is it only you that is coming? No other person is coming. So government has forgotten us, or your organization has forgotten us. So I think I will need some clarification if there is anything put in place to assisting those in the riverine area. Thank you.
Okay, I hope I can quickly ask this question. My name is Onyinye Ede. I am a research fellow, but also with the Strong Enough Girls Empowerment Initiative. And I'm curious to learn more about the patent medicine stores and where do they get their supplies from? That's something, if you can enlighten me more about that. Thank you.
We are coming back here at 2 o'clock. So I'm sorry. Please look at their faces very well and sit on their table during lunch, because they may not have time to answer your questions. And gladly, most here and is always in the ministry, so you can always reach him. Please, I'm sorry, but you saw the chairman of the LOC just now. He says, I have to end now. But I have to thank all the presenters. It's nice seeing her again after a long time. And I want to thank the audience for listening very attentively, because I put in this. But before we go for lunch, as I said earlier on, we must be here at 2 p.m. for plenary, so you have to eat lunch very quickly, and please come back. The lunch is outside of the grill. and you must come with your meal ticket. Thank you very much. Let's go for lunch.